Hi, I'm Deepa, and as Tilo described, I was the Knowledge Transfer Partnership Associate on this project from 2010 to 2012. Currently, I'm studying at McGill University in Montreal, Canada, which I wish I could say always looked like this, but given the huge snowstorm we had yesterday, it currently looks like this, which is the same view. So whatever the weather you're having in Edinburgh today, perhaps you are just pleased you're not here. As a Knowledge Transfer Partnership Associate, I was based more than 90% of my time in the Glasgow office of Healthcare Improvement Scotland, though I was officially employed by the University of Glasgow. This meant I spent some time there as well. My position in this project could be summed up by the red dot, so I really was in between the two universities, Glasgow and Dundee, and Healthcare Improvement Scotland. The problem that we were trying to address, as Tilo described, was accessibility of patient-reported outcome measures to people with low literacy and learning disabilities. So our primary stakeholders were patients and clinicians who would ultimately be using these measures. It is entirely possible that these stakeholders never had anything to do with a university or the world of academic research, but nearly everyone has had some interaction with the NHS or at least knows what it is. This means that our stakeholders were more explicitly linked to the health system than a university. At the same time, expertise from an academic point of view on issues of accessibility, as well as expertise on research methods and analysis, was at the university. Normally, university researchers could still undertake this work. They could go through contacts that they have within the health system, or they can parachute in to do a specific project with special permissions. Before I even go into describing the benefits of collaborating over this approach, it is probably already obvious why being within the health system and basing research within it would be more advantageous than staying external and doing the research that way. This is especially the case if you're hoping that stakeholders will actually take up the results that you find, and the results are actually linked to the reality of what's going on. When it comes to our project, it really did sit quite well between the university and Healthcare Improvement Scotland. The expertise, as I said, on low literacy, learning disabilities, and patient-reported outcome measures academically was within the university, but we could use channels through Healthcare Improvement Scotland to disseminate and ensure the results were taken up. I'll now discuss some of the benefits of the collaboration. The first was having two different cards to draw on in different settings. By this I mean sometimes having the university affiliation and sometimes having an affiliation to the NHS helped earn credibility with different groups of people. I can think of the perfect example when I was out interviewing a particular patient and she was a little suspicious of my intentions. That's not uncommon because if you really haven't had any exposure to the world of research, why I'm out trying to interview these patients actually seems a bit questionable. I was trying different things anyway to earn her trust because I wanted her to share her views with me on the questionnaire. Finally, what actually worked in the end was telling her about my NHS affiliation. That was something she was familiar with and could relate to. And we ended up having a really good interview where she had a lot to say about this questionnaire. I know that getting those views wouldn't have been possible had I not had this NHS affiliation to earn her trust. The university affiliation was helpful in different settings. When I was at conferences or following up on academic contacts based in universities, actually it was quite helpful to be part of the academic world. A lot of people had done research on low literacy and learning disabilities and could point me towards a lot of existing literature. In using these contacts and credibility within the academic world, we could avoid duplication and also apply what others had found to our project. The next point is similar, but I'm referring to the diversity of contacts we had from many different areas. This is a network map that I made towards the end of the project that showed everyone who contributed in some way or another to our project. The different colors represent the different sectors, and this involves academia, public sector, charities, and patient groups. As you can see, we had representation from across the board. This actually was not incredibly difficult, and I think this is because we had a very strong baseline. We had an entire network of contacts through project members at the university and another network through project members at Healthcare Improvement Scotland. In turn, their contacts gave us even more names, and everyone was really ready to engage because this went through existing channels. This really enriched our project because people from different backgrounds could bring different bits of knowledge to the table. For example, when I met with someone from a charity for people with learning disabilities, she told me about this software to create visual cards to help us interview people with learning disabilities. This proved really useful and made our interview technique a lot better. Engaging such a diverse group of people evidently brought with it another challenge. How do you keep everyone involved over 2 years when there isn't always the opportunity for involvement, but you still want them to be available when there is the opportunity? We accomplished that using a monthly update, so anyone who wanted to follow the project could really easily do so by having an update appear in their inbox every month. We also included opportunities for involvement through that update. The final benefit I'll discuss is the fact that through the setup of our project, we were actually able to conduct research to address a public health need. You'll often hear these terms such as research-based decision-making, evidence-based policy-making, applied research, public health research. But often these terms are used tokenistically. For example, a researcher at a university might conceive of a project to address a public health need that they think exists and sort of hope that it's taken up in the end, without any real means to ensure that this is the case. At the same time, someone in a public health sector or any decision-making institution might already know the decision that they want to make and sort of look sparsely at the literature to find a study somewhere to justify what they already decided to do. The setup of our project helped to avoid this kind of tokenism. First of all, the problem was identified from within the health system. So in that sense, the need actually did exist and the problem did exist. Dissemination was built into the project from the outset, so there was little risk of calling it applied research, but not really being able to apply it in the end or just hoping that it would be applied. Secondly, we didn't know in advance the recommendations we wanted to make. A big part of this project was the primary research, which was grounded in the university. So in the end, the user guide that we developed and the recommendations that we made in that guide was actually based on research. Those 2 points illustrate how the setup of our project could avoid the tokenism that you sometimes see when conducting research to address public health needs. Luckily for us, there were a lot more benefits than challenges, but I'll briefly outline 3 challenges that are probably typical of projects that have a similar setup to ours. The first is aligning priorities. Different things are rewarded at different places. In universities, it's all about academic publications, but that's not the case in the public sector at Healthcare Improvement Scotland. We had outlined in advance exactly how many academic publications we were going to produce, as well as other deliverables such as the user guide we eventually disseminated. Knowing this in advance was helpful. I could see how that could be a source of tension if it wasn't known in advance, because balancing academic priorities with public health sector priorities would be important to ensure the project is mutually beneficial. The second challenge was operating a research project within a template that was typical of public sector projects. The timelines for research are a bit varied, and we found it a little bit difficult to fit the first year of research right into what we had outlined to begin with. For example, in the first year, it took us a lot longer to get research ethics approval to conduct our interviews than we could have really outlined in the project template when we were initially planning it. We had enough flexibility in the management of our project that we could play with time a bit and shave off time elsewhere. But knowing in advance that timelines for research might not exactly gel with timelines expected from a public sector project would be important. Finally, we had a bit of difficulty at the end demonstrating the value of our project in quantifiable terms. The indicators we had to use for success were actually predefined and involved things like changes in revenue as a result of the collaboration. Everyone can imagine the shock factor if we were able to say that collaborating with the university managed to increase Healthcare Improvement Scotland's revenue by 400%. This didn't happen and couldn't have happened. A lot of the value added from the project came from intangible things, such as new relationships built and trust across organizations, or changes in attitudes among clinicians using patient-reported outcome measures with people with learning disabilities. We weren't really able to capture this in the final report because of the predefined template. I think defining indicators for success that will capture things that are a bit less tangible would be important in this kind of project, as it's important to recognize that a lot of the time, while it might not be explicit in numbers, there is still value added that is more implicit. And with that, I'll just recap. Some of the key benefits of our project were having 2 different cards to draw on in different settings, a double network of contacts to draw on, and the ability to conduct research to address a public health need in a non-tokenistic way. Some of the challenges that might have been bigger hindrances than they actually were was aligning academic and public sector priorities, demonstrating and capturing implicit value, and reconciling timelines. In November 2012, we had a dissemination event towards the end of the project. People from all the sectors I mentioned attended, and it was really nice to have people there from such different backgrounds, all discussing the same thing on the same level. I think it really was a strong demonstration of the value of the knowledge transfer partnership, because it would not have been possible to draw such a diverse group of people together in a meaningful way in any other setup. And with that, I'll close off. If you made it to this point in the video, it means the video worked, which is great. And thank you for watching, and I'll pass you back to Tilo.